To be here, and I'd like to thank Julio and the organisers for this opportunity. Sorry that I can't be there in person, but my aircraft will have left by the time this talk is being presented. I'm going to talk on the impact of ART on the transmission of mycobacterial tuberculosis. And I'm going to separate the talk into four main areas. So I'm going to talk about what is known about the effect of antiretroviral therapy on TB incidence, both short-term data and long-term data. I want to look and just share with you some of the data on HIV-TB incidence in areas where TB is particularly endemic. And I come from a city of Cape Town with 3.4 million individuals, and we have 3 times as many TB cases per year as the whole of the United States of America. So it's a highly endemic disease in Cape Town. And then I'd like to look at the effect of ART at a population level, and then just explore, will TASP impact at all on TB transmission? Because if we can show benefit for HIV negative population, that really strengthens the TASP argument. So first of all, this is a meta-analysis of the benefits of antiretroviral therapy in cohorts, and showing the benefits relatively short term. But this was touched on by Brian Williams yesterday, and you can see that there's a little bit of variability, but there is probably a 60% reduction overall in TB incidence in HIV individuals on ART compared to those not on ART. If we look at that a little bit more carefully, and here, this was some data we presented quite a few years ago. You can see that the benefits differ by CD4 count and clinical stage. So if you look at the panel on the right-hand side, you can see in the grey the TB incidence rate in our cohorts without ART, and in red in those individuals who started ART. And you can see that whilst the benefits are greatest when we treat someone with low CD4 count under 200, that the residual rate is in fact much higher than the residual rate of those with higher CD4 counts. So this means that we will be making people live for much longer, but that they are at increased susceptibility for TB. So we're increasing the number of susceptibles in the population. Now, if you look on the left-hand panel, you see the same thing by stage, that if we wait until patients are very symptomatic, we get tremendous benefits, but we're left with long-term susceptibility to TB in the red. So if we look at that a little bit more carefully, if we look at cohorts that are starting antiretroviral therapy, we see that as time goes by, and this is some data from Steve Lawn showing 3 years of antiretroviral therapy, you can see that the TB rates, incidence rates, decrease with time, but still remaining somewhat close to 5% per annum, which is unacceptably high. If we look at the data in a slightly different way, and here what we're looking at is a cohort of individuals on antiretroviral therapy. This is the Guguletu cohort with 3,000 patients on treatment. And what I've shown is contours, and the dotted contour is 200 cells and CD4 cells, and you can see that early on in therapy, 80% of people were less than 200, but subsequently about 10% of people are left in that strata. And similarly, there's a contour for 500 and 1,000. And what I'd like to just show is that when we looked at time spent in these cohorts, you can see that there's a tremendous difference in TB rates, that in those that fail to get above 200, the TB rate is 10 to 15%, where it's about 5%, 200 to 500, and it goes down to about 1.5% between 500 and 1,000. That's still about twice the background rate in Cape Town, but it shows that early treatment, high CD4 counts are what we need in order to prevent TB incidence. So let's move on to the second topic, and this is the incidence of HIV-TB, where TB is endemic, as I described in Cape Town. So there's about 30,000 notifications per annum. This is data from 2009, and what I've done here is I've just shown the HIV positive, known HIV positive TB cases, and you can see this interesting distribution, that in blue these are new case TB. These are the people who are presenting for the first time to the TB control program, and 30% in the orange are in fact being retreated. And I won't show you the data and go into it, but if you look at the failures of initial therapy, they are not sufficient to explain this. So something else is going on to explain this very high retreatment rate. So if we use the denominator of the HIV positive population of Cape Town, and we have this from actuarial models, we can give you the TB incidence rate for both retreatment TB and for new case TB. And you can see that new case TB stays around about 4 to 5% stratified by age. But retreatment disease starts at about 1,000 per 100,000 and increases threefold with increasing age. Together, those rates go from 5% in 20-year-olds to about 8% from the age of 45 onwards. And that's an HIV-associated risk ratio of 22. So this is an amazing burden. Why do we think that's happening? Well, we think it's because we have an extremely high force of infection. So this is just an example of the proportion of the population that would be infected by age if we had a force of infection of 1% annual risk of infection of TB. And you can see that by the age of 60, a little under 50% of the population would have been infected once, and about 10% would have been exposed more than once. But in fact, what we think the situation in Cape Town is that we think we have a force of infection that's between 7 and 10%. And here you see this movement towards the top left-hand corner, that people are exposed once, much earlier in life, and the other curves are showing second, third, fourth, fifth, sixth exposure, etc. So people living in Cape Town are exposed to multiple infections, and we think that's what's been driving the retreatment rates. So just to summarize what I think happens in Cape Town, at the age of 5, 20% of the population are infected with TB. These are from TST surveys. Before sexual debut, more than half of individuals are infected with TB, and by the time they are presenting to antiretroviral clinics, 90% of individuals will have already been infected with TB. So, why have I stressed that? And I think this is a particularly interesting concept, especially from the test and treat point of view. So here we have a cartoon. On the upper segment is the CD4 count of an individual getting infected, and then for the subsequent 10 years, CD4 count decline, and then the CD4 count increase with antiretroviral therapy. And in the blue, the second curve, you see what we think is happening to the TB rates on a log scale. So let's take you through that a little bit more carefully. So what I think happening in Cape Town is that HIV-negative individuals are in fact being primarily infected with TB before they get HIV. Then I think that it's possible that at HIV seroconversion, that in fact there is a burst of new TB cases associated with that CD4 count decline. This would be analogous to using tumor necrosis factor blockers, which have a peak of TB for about 90 days afterwards. So after that, there is then the slow progressive CD4 count decline, and we would get reactivation and new infections during that period because it lasts for 10 years and the force of infection can be exerted. Then we have this acute immune reconstitution during treatment, which would flush out any TB prevalence there and turn it into incidence. And then we're left with people who have chronic immune recovery on antiretroviral therapy. And those individuals will have gone through all these sieves previously, and I think it's highly likely that the TB incidence of our patients on antiretroviral therapy is new incidence rather than reactivation TB. So let's now look at the effect of antiretroviral therapy at a population level. And this is the population that I'm going to share the data with. This is one of my research sites. This is Massapumaleli. It's a well-defined township with just under 17,000 individuals living in relatively cramped area, with an HIV prevalence of 25%. And TB incidence actually peaked in the general population at 2,500 per 100,000. That was 2.5% of the population developed TB every year. Well, we performed two prevalence surveys, one very early on in the introduction of antiretroviral program, and one after we've treated a significant number of individuals. And it's a random population survey, no pre-screening. Everybody gave us a sputum, or we induced sputum, and we defined TB as two cultures with Mycobacterium tuberculosis of the same spoligotype. And this is what we found. So here are three panels. Let's look at the left-hand panel first. 2005, you see that about 3% of the population were either on TB therapy, which is the grey, or in the red zone had newly found culture-proven TB. And you can see by 2008 that there was a significant drop in both previously recognized and unrecognized TB. Middle panel is showing what happened in the HIV uninfected population. You can see essentially there was no difference. All the signal changed in the right-hand panel. And there in 2005, you can see that 9% of HIV-infected individuals had tuberculosis. 4% of them were recognized non-treatment, and a further 5% you could culture TB from. Now, by 2008, a significant drop. And the drop was greatest in those in the red hatched areas that had not previously been started on therapy, TB therapy. So let's look at this slightly differently. If we look at the incidence of TB, and these are the notification data, you can see here in this graph in red increasing ART coverage. And this is much lower than I thought it was, because this is people who at any given time taking antiretroviral therapy. So it's not the number of people who have started. It's not the number of people who've stopped and started. It's the number of people who are on at any given time. And it's increased to about 30% now of the HIV-positive population of Massapumaleli. And draw your attention to this phenomenon, that from 1997 onwards, there was a relentless increase in TB rates, and it decreased. Now the question is this associated with the antiretroviral therapy? So first, let's look by HIV status. In blue, you have HIV negative. In red, HIV positive individuals, incidence rate. And you can see that all the change took place in the red, the HIV positives, and there was no significant difference in the HIV negative TB rates in this community. If we then separate the HIV positives into those that are on antiretroviral therapy, which is shown on the right-hand panel in green, and HIV positive not on antiretroviral therapy in red, you can see that the biggest drop is in those that are on antiretroviral therapy. And you have this interesting phenomenon that to begin with, we actually increased the incidence rate, and we think that's a phenomenon associated with increased case finding. But as the CD4 count profile of this cohort increased, so the TB incidence rate dropped. The rather disappointing that the other HIV positives, that the rate is staying much the same, and that's either due to the rate at which we're putting people on antiretroviral therapy and taking out the sick individuals, but perhaps also it reflects the fact that in this community there's about a 10% per annum immigration rate, and of course we can't expect our TASP or our antiretrovirals to be affecting those that are coming from outside the community. So let's look at the last topic. Will TASP impact on TB transmission? Now, this is a fairly old meta-analysis, but it really confirms the conflicting data around the infectiousness of individuals with HIV? Does it increase or decrease? And you can see that there is a majority of the studies, the transmission is less in HIV positives, but there's a lot of spread. So it doesn't seem as though it's a massive effect. So we looked at this, and this is looking at two panels. It's a geographic information system. We've looked at children in this community who either have acquired infection, TST, on the right-hand side, or acquired TB disease on the left-hand side. And we cross-correlated this with the TB notification data to see if there was an association between the childhood infection disease with TB with adults living on the same plot. And we found there was a strong association between the number of adults with smear-positive disease that the children met. But it was not associated with the HIV status of the adult, which sort of fits with the last data, that it looks as though they're not particularly more or less infectious, that the big driver is whether they're smear-positive or not. However, when we now look in blue at the under 15 TB notifications, we haven't seen a decrease in this. And this is somewhat surprising. I would have expected that children would be more reflective of a decrease in TB transmission in the community. And that doesn't seem to be shown in this study. So let's wrap that all up. What do I think I've shown you? I think I've shown you that CD4 count really determines TB incidence both pre and post-ART. That treatment as prevention will decrease TB, particularly in the HIV-infected population. That associated with this, and this is an interesting phenomenon, that the case finding will have to be improved, and that there will benefits will accrue from that with the introduction of TASP. And obviously with some modification for those testing HIV negative, if there's some case finding, we could have a big population effect. And then I think there's an intriguing point which Brian highlighted as well. If new case TB is strongly associated with seroconversion, do we now have a subset of HIV TB which its incidence is actually a function of the HIV incidence? If we do, then it would mean that we would be identifying people very early. Unfortunately, we'd be identifying them after they had TB, so they couldn't benefit from that. But it may also be a measure that we can use in our studies to see if there's a decrease in HIV incidence. And then lastly, I've really left the last point a little bit open. It would be lovely if we had a TB transmission dividend bonus, which affected HIV negatives as well as positives, but at present I don't think we've got hard data to justify that. So thank you very much for your attention, and just like to acknowledge my colleagues and co-workers. Thank you very much.